good afternoon. I know some people it's morning, some people are afternoon, some people are even like good evening, early evening. So thank you very much for joining us again in this recurring webinars trying to discuss some challenges our colleagues in Gaza are facing with some challenging cases. Today our speaker will be Khalid. We met with Khalid last webinar. He talked to us about some horrible experience he had when he was arrested and detained for almost 6 months in the Israeli Sidi Timan detention camp and then later at Ofer prison. Khalid is back again working at Nasser Hospital in Khan Yunis. He is going to discuss with us some challenging cases he had faced recently, and hopefully to get some inputs from our panelists today, Dr. Hani Al-Qadi. He's a consultant trauma and critical care surgeon at Sultan Qaboos University in Muscat, Oman. He actually was one of my co-partners in my last visit to Gaza, where we had to do a lot of common cases together trying to save people's life. And then our also co-panelist is Dr. Fitzgerald Simon. He's the trauma critical care surgeon from Brooklyn in New York, and he has actually been a huge supporter for what's happening in Gaza in terms of raising awareness. He also has a special podcast or radio talk about what's happening. So thanks, Simon, for everything you're doing for us. So we have Khalid with us here. Khalid, the mic is yours. Go ahead, please. Thank you.
Assalamu alaikum. Hello, everybody. I'm waiting to enter the Zoom webinar through my laptop. Give me a minute.
Take your time. Hani, Simon, you want to just have a comment on these webinars? I know you guys both have been advocate about it, but by the time Khalid gets his webinar going on or his PowerPoint going on, Hani, can you comment, please?
Well, thank you very much for inviting me to be one of the panelists today. It's an honor to be with you all. Definitely, these webinars are very important to shed the right light on the atrocities that are happening in Gaza, with all the attempts to kind of change the narrative of what's happening in Gaza. And also involving international panelists and participants that will also help in showing different point of views as to what's happening there. So good luck, and I hope these webinars continue, inshallah.
Simon, thanks for being with us.
Well, I just wanted to say thank you for having me, and Khalid, it's great to see you. And I think we've never spoken, even though we're co-authors on that Lancet paper. And I just wanted to say I appreciate the opportunity to participate, but I do so humbly. Probably Khalid has seen a lot more trauma, especially in the last year, than me. We're about the same age and place in our training. I think what I can offer is, what we would do in New York City, and think about the resource differences and the situation differences between here and Khan Yunis. So definitely, I appreciate the opportunity to participate, and what I offer, I do so humbly. And Khalid, I'm really grateful to see you, and happy to be participating in care with you with patients at Nasser Hospital again.
Thanks, Simon. So Khalid, you send me your presentation. I'm gonna pull it up.
Presentation with your screen.
Yeah,
because I'm going to enter the webinar through my laptop.
Sure.
Start with the cases, a file called test case.
Yeah, just give me 1 second. Okay. Open with Microsoft PowerPoint. Okay, Khalid, let me share my screen. And you can tell me when you want to do the next slides.
Okay. So, hello everybody again. First, I will present 3 cases we received in the last 2 weeks. The name of the webinar is challenging cases, but actually every case we receive here, when we compare this with the shortage of equipment we have, shortage of staff we have, and the mass casualty event that we receive every 2 days we have a mass casualty event. It's a challenging case. So, but these 3 cases, some of them still under treatment here at Nasser Hospital. I was hoping that I'm joining through my laptop to show you some data about the last months at Nasser Hospital, the number of casualties that we receive, the change that in the quality of cases, the types of injuries that we receive. I hope in the meanwhile we will discuss these cases, and after that we will go through the current situation at Nasser Hospital. First of all, this case is a 14-year-old boy called Ibrahim. He brought to ER due to a shrapnel injury in the right upper quadrant.
Uh,
1 minute.
yes, Khalid. Khalid. So we lost Khalid. Let's hope he will join again. So I think he should be able to reconnect soon. Khalid actually he joined as an attendee. Okay, let's promote. Yes, Khalid. Promote to panelist. Khalid, yes. Khalid, you're with us now. Khalid, can you unmute yourself? Yes.
Okay, can you hear me now?
Yes.
Okay.
Yeah.
Let me share my screen.
Sure. Good. أنا حطلع من السكرين تبعتي.
Okay.
Yes.
Okay. These data about the last 5 months, when the Nasser Hospital restarted again to receive new cases. The difference in the last 5 months is that we received new types of injury, and the number of injuries we receive here, like the double of cases that we received in the start of the war. All of this is due to the forceful displacement of Palestinians from Rafah city and from the north of Gaza. Nearly 1 million Palestinians were in Rafah city has been forcibly displaced to Khan Yunis city or Al Mawasi, which is the western side of Khan Yunis city. And because of that, let me share the graph of the admissions, the last admissions. Admissions compared with the last year. if you see, there is like from 3,000 to nearly 4,000 cases we received this year, comparing the last year, the years of the war. In October, 3,000 cases per month, but this October, like nearly 4,000 cases per month. This number of cases that we receive and admitted to the hospital increase the burden on our staff, but that we have still shortage in medical staff here and in certain specialties. And also, we still have shortage in equipment inside the operation theater, especially the abdominal swab that we desperately need in cases with the trauma and the bleeding, and also the materials and equipments we use for hemostasis. Like we don't have ligashures, we don't have monobolars. Actually, we're trying to, we don't have that. All what we use is a disposable pencil or handle switch that should be used once or twice, but we are trying to sterilize it again and again until it's broken and not working properly. And actually, the EMT, the emergency medical team, who are visitors from outside, specialists from outside, are surprised how we can adapt to this shortage and how we can use these broken instruments. But the idea is we have to do it because there's no other alternative. But till now, after 1 year of the war, we still have a lot of shortages in several areas. The last case that I'm working on as a patient, post-operative, has a complication with intra-abdominal abscess. I'm looking for a nephrostomy set or a big tail tube to use it for ultrasound guided. I did not find any in the Ministry of Health hospitals. This is my last case that I'm working on. These graphs have a lot of data, but if I want to go in details, I will take more than 2 hours. But I just wanted to show you these numbers of admission that we have a doubling of cases, despite we still have shortage of healthcare staff and shortage of equipment. The other thing that I want to talk about is the quantity or quality of cases, quality of injuries. Now more than 90% of people in Khan Yunis and in the middle area of Gaza Strip are living in tents. So if airstrike happen at that area, there is no protection for people. And we receive new casualties that their body has been melted due to the flame or the temperature of the explosion. So we receive more pain cases, but the surprising and the shocking, we have the percentage. If we receive 100 cases per mass casualty, the percentage of the killed ones increased. We received, like in the area of the war in October 23, if we receive a mass casualty, 20 or 30% of cases are killed, but now they reach more than 60 and 70% of cases because there is no walls to protect them from the explosion. I have a slide here. This is the number of injuries compared with the last year. Sorry. There is a graph comparing the percentage of the killed. I think this one.
Yeah.
The number is increasing comparing with the last year because I said that forceful displacement of Palestinians toward the Khan Yunis and Al Mawasi, which has now more than 1 million.
This is at Nasser Hospital, yes?
Only Nasser Hospital, which is covering the majority of the secondary and tertiary healthcare service in the southern area of Gaza Strip. So this graph, as you see here in October compared with 2023, it's not doubling, it's fifth time. Okay. Now I will move to our cases. If you have any questions regarding this.
So
Before I move it,
I can comment myself on this shortages, Khalid. The Israeli army is actually preventing a lot of, human aid to go into Gaza. I am myself involved with a lot of, let's say, efforts in Jordan trying to get things into Gaza. You'll see that for the last 2 to 3 months, actually no food, no tents, no clothes, and no medical supplies. We were able to get into Gaza for almost 3 months, although we have hundreds of thousands of tons of medical aids, medical supplies, foods ready to go into Gaza, but the Israeli army is doing it in a way to really increase the suffering. And myself, I can speak, being at the Al-Aqsa hospital and the public aid hospital, that I had to work without a cautery, without an abdominal swabs in the bleeding cases, no surgical stapler. So most of the anastomosis, you do it hands-on. The ligature is not even a luxury. It's something you dream about it. And I confirmed the issue of the pigtail and the nephrostomy tubes. That's something, if you find one, your patient is lucky, so you don't have to do a laparotomy for a small abscess. So I just can't concur your comments, and I don't know why they're preventing medical supplies to go inside. I think it's just to increase the suffering of the patients.
let me elaborate more to show my colleagues how we now, as healthcare workers, as doctors, as surgeons here at Nasser Hospital, and also in other hospitals, 90% of doctors here are living in tents, and their family are living in tents. So they came here to work, worrying about their families. They're working more than 70 hours a week to get a good salary. But this salary is not doing anything because everything here is expensive if you want to try to buy something from the market. The other thing that after you finishing your 24 or 30-hour working continuous work with mass casualty events, you have to go back to your family to provide them foods, to stand in a queue to get a bread or a drinking water for them. And so our job is not, when we go to our home, we're not resting because we have more responsibility to do. I will start, if there is no other questions, I will start with
Right.
the other presentation. Are you seeing my screen?
Yes.
Okay. I will discuss 2 or 3 cases according to the time. As I said earlier, these cases still treated under our department. First case is a 14-year-old boy brought due to a shrapnel injury in his abdomen. By primary survey, he was stable at the emergency department, conscious. There is a 2-centimeter laceration at the right upper quadrant, nearly at the costal margin. Initial ultrasound at the emergency department, there is a mild to moderate free fluid collection in the abdomen. Because the patient is stable, we sent him after resuscitation with 500 cc saline and IV cannula blood sampling. We sent him to CT. The CT of the abdomen, I don't know if I can share the CT. It's showing, let me share. Because I cannot upload the CT, it has a lot of
Images.
pictures. Yes.
So 14-year-old with penetrating injury to the right upper quadrant. This is the case, is that right?
Yes. Yes.
Oh. And it was part of a mass
Okay.
casualties. Yes, Khalid, it was part of a
Yes,
mass casualty.
part of the mass casualty.
Yes. Maybe show us like the money in the CT scan. Go down, scroll down.
I will do.
Yeah, and let's just
But
get the money down.
Are you seeing it?
Yeah, we see the images. You have still images, but if you scroll,
Still image. Okay. We'll share this one. You see, this is the topogram.
yes.
As you're seeing, this like an explosive bullet or explosive shrapnel with multiple fragments inside the right upper quadrant.
Mhm.
I don't know if I can move
He
to
already
the
has a
other.
chest tube in.
Yes, we did a chest tube because it has decreased entry in the right side.
Okay.
We did it before the CT.
Okay.
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 This CT is a follow-up
I see.
CT. Actually, I was not able to get the original one, but the problem is he has a hepatic injury.
Mhm.
Are you seeing it clearly? Because or
Yeah.
I'm moving too fast.
Yeah.
So most of the injury is the hepatic flexure. In short, I will summarize the report. He has an injury in the liver,
Mhm.
with injury in the hepatic flexure of the colon,
Mhm.
and also injury in his kidney.
Mhm.
So he underwent a laboratory, emergency laboratory at that time.
Mhm.
Because after 30 minutes, he started to develop hypotension. We started a blood transfusion at the emergency department. Then we sent him to the operation theater for emergency laboratory. The finding in the abdomen, we have blood clots in the Morrison pouch and the pelvis. Also, we have an active bleeding from a satellite lesion in the superior posterior surface of the right lobe. You can say in the segment 7-8 or in the superior posterior surface under the diaphragm. Also, you have a through and through injury, the hepatic flexure. There is like a contained hematoma in the kidney, but from the CT image, we saw that it is a small injury or mild injury in the kidney. So we did not open the gyrotous fascia. We just managed it conservatively. But at the whole time during the surgery, despite the resuscitation with blood components, the patient is still hypotensive. So we decided to do a damage control surgery, just debridement and primary repair of the colonic injury, anterior and posterior aspect of the hepatic flexure, and putting 5 large abdominal swabs, then sent him to the ICU for resuscitation.
So Khalid,
Yeah,
just
yes.
go back, Khalid. So how many units of blood you given him by the time you've decided to do a damage control? Like how many times, how long was it in the operating room, and how many basically blood products you've given him so far?
I tried to recall these data, but the problem, we don't have papers here.
I
We
see.
used to do the patient data is in paper. When I want to request for a CT or a chest X-ray, I use a small piece of paper because we don't have paper to write in. So actually, I was not able to get this information, but he at least get 3 to 4 backed RBCs on the operation theater.
I see. And then Khalid, the other thing is it's already cold in Gaza, and we don't know how long this patient was basically until the time of transfer. And I know that there's no electricity, and these patients don't have even, clothes to cover them. And that's something also you might comment about this.
Yes, the thing that I must to talk about the current situation also, we in the past before the Israeli invasion to Khan Yunis city, when we hear a bombing, we rush to the emergency department because we know that within 10 minutes the ambulances will come to the emergency department. But now we hear a bombing, and after 1 hour, the first ambulance start to show in the emergency department gates, because all of the infrastructures, the streets has been destructed. We don't have also if the patient or if the bombing is in the tense area, it's difficult for ambulances to move quickly to the emergency department or to the hospital. And this is also another cause for the raised percentage of the killed ones, because most of them will died in the street. They need like half hour to 1 hour to reach the emergency department. So this patient, he was living in Al Mawasi area. The bombing was to his family. He lost one or two of his family members. But he reached the emergency department after like 40, an average 40 minutes after the injury.
Okay, so you decided to go for damage control. So you packed, and
Yes.
the reason was hypotension or instability. Was it active bleeding from everywhere, or
Yeah, the active bleeding was from the surface of the liver only, because when we do CT, we directing our focus during the surgery is on the tract of the injury or
so
trajectory of the bullet or the explosive or the shrapnel. So we focus on the liver. We did a formal exploration. We did running of the small bowel and the whole colon, but we focus on the liver, hepatic flexure, and the kidney. So the liver has an active bleeding because of the active bleeding, and in the difficult area, in the retrohepatic area, superior posterior surface, we did backing. We tried to do a liver stitch and gel foam, but we could not make it easily. So we decide after 20 to 30 minutes during surgery to do damage control.
Let me ask Simon. Simon, so you have this
surgery.
This bleeding, like in the 14-year-old, has been in the street, cold area for a while. You have limited availability of blood products, and you're trying to control this. The high looks like on the CT scan at the dome of the liver. What options you have, Simon, here that you can help Khalid with before you decide for just packing and go out?
So I would actually, if I may, I might even back it up a little bit, because it's true that a penetrating injury to the right upper quadrant sometimes can be managed non-operatively, if it's only a liver injury. But if it's like an explosive injury, especially a young person, delayed presentation, that the blood supply is limited. When you confirm with ultrasound that there's free fluid, in my emergency department, even though the CAT scan is right across the hall, it takes time, and I think I would anticipate that a patient like that might get unstable in the CAT scanner and would probably try to go straight to the operating room. There may be resource reasons why that getting the scan makes sense, but I would be worried about decompensation and would go straight to the operating room with the information that we had probably. And I will say that when it comes to dealing with bleeding liver, I like packing. I go to it first. At least you get your temporary hemostasis. If the blood doesn't soak through the packs, if you can get temporary hemostasis, then you can focus on the rest of the injuries like you did. You can deal with the liver, with the colon, and leave the liver alone. And now, and I often, if the packing works, then often I will leave it in and be satisfied for damage control for temporary hemostasis. Why? Because I rushed to the operating room without getting a CAT scan. So I packed, I dealt with the colon. You're worried maybe about the kidney or retroperitoneal structures, but if there's no hard indication to explore the retroperitoneum, in my circumstances in New York City, then I can get a CAT scan after the damage control surgery with a temporary abdominal closure.
Okay.
And now that being said, sorry, go ahead.
Yeah, go ahead. Yeah.
Well, other options, right? If it's a superficial bleed, we have an argon beam, which can be used for that. I'm guessing that you don't have that. You can turn your cautery all the way up to 80 and arc it, and it works a little bit similarly, is an option. But if it's a deeper problem, that's not going to work. You can have a big blunt needle with a chromic and put some stitches and put some hemostatic agent there. But again, if you guys are light on hemostatic agent, I would, in addition to the packing, cover the injuries with hemostatic agents, like Surgicel, Surgiflow. We have Everest patch. We have a lot of options.
Hani, you want to comment, Hani, very quick?
Yeah, I agree with Simon with all these options. But being in Gaza before and operating on bleeding livers, we don't have many options. Um, what I would do is pack, like Simon said. Uh, the other thing is, if it is feasible, you can do a tractotomy, split the liver open, and then just burn the hell out of the liver surface with cautery, and then pack.
What I would comment also, Khalid, here is that it's a 14-year-old, so I think it's easy to were able to get an exposure. But operating in older adults with muscles, sometimes to get a better exposure for the liver, you might have to do basically a horizontal incision in addition to your laparotomy, like a reverse L or
Maximize.
yes, I've done this several times in Gaza to take care of some bleeding livers. So don't shy from just opening the transverse incision to get a better exposure up in the dome and to get things in a better control. And then you have to do maybe some liver mobilization, little mobilization, but don't shy away from doing a big incisions in these cases, trying to save this patient life. Go ahead.
And,
Go ahead.
and I would just add, if I can get hemostasis with packing, I'm very reluctant to mobilize the liver on the index case.
Absolutely.
Because I've seen, in my career at the M&M, I've seen cases where they had temporary hemostasis, and in trying to get definitive hemostasis on the liver, have unroofed something retrohepatic and lost control of the situation. So, me personally, if packing works, I'm totally fine to pack and run.
Great. Go ahead, Khalid.
I have a question to Dr. Khalid. You said there's something in the retroperitoneum?
I was talking about the kidney. We saw the kidney in the CT scan. It's just the upper lobe of the kidney has some shrapnel without active bleeding or extravasation of contrast. And we also, during the surgery, we don't have an active bleeding from the retroperitoneum. We called the urologist here to see it's operatively, but he decided not to open the urethra fascia and to keep it for conservative management.
Great.
Okay, just like something that is always said that if the retroperitoneal hematoma is not expanding, then I wouldn't explore. It's just very difficult to see like an actually expanding retroperitoneal hematoma. I would say in penetrating injury, any retroperitoneal hematoma, I would explore with proximal and distal control before I explore it. Because to actually to see actually if an expanding retroperitoneal hematoma, that would require a lot of bleeding to create this effect. Thank you.
Thank you. I will add 2 comments for your questions. First, regarding the damage control surgery here at Gaza, because we have a lot of mass casualties and we are not prepared. We don't have the time or privilege to do the definitive management at the same time. We receive dozens of cases. We have a lower threshold for damage control surgery, just open, control, bleeding, contamination, sent to ICU. We don't have time. We want more operation theater rooms for the coming patients. So we have a lower threshold, especially at the mass casualty events, to do a damage control surgery, even for bowel surgery, because we don't have enough operation theater room at that time. The other thing regarding the kidney injury or the retroperitoneal injury, surely after 13 months at war, because most of our casualties we receive here is due to shrapnel injury or bullet injury, because alhamdulillah, we have CT scan. So most of our job are directed to the tract of the trajectory. We see the CT, we read it several times to see where is the shrapnel is, and we can decide before we go into surgery the amount of damage happened to this organ. Because of that, we did not do exploration of the retroperitoneal hematoma. There was no active bleeding, and we left the job for the urologist actually.
Okay, Khalid, go ahead.
Going back to our case. So the patient sent to the ICU, and after 48 hours resuscitation optimization, his lab results were normal. The total transfusion through the operation theater and in the ICU, 4 packed RBCs, 4 fresh frozen plasma, and 2 platelets. The second surgery is removal of pack. The abdominal swab, we left 3 abdominal swab under the liver, 2 abdominal swab in the suprahepatic area at the site of the trauma. The thing that we saw that bowel abnormal, we did also a formal exploration for the small bowel and colon for any missed injury. They were normal. The thing that we noticed that the large abdominal swab over the liver is soaked with bile, so we removed them. We are seeing bile leaking from the satellite lesion in the superior on the dome of the liver. So we did irrigation with warm saline, the 3 drains inserted over the diaphragm and under the diaphragm and also in the pelvis, and we sent the patient back to the ICU with permanent closure of the abdomen. During the first 4 days after surgery, he was doing fine, but after 4 days, he started to develop shortness of breath with no cough, mild abdominal pain, mild distension. He tolerating the soft diet, but he started to have a high-grade fever, like a hectic fever, for after 4 days of the surgery. By examination, the abdomen was soft and lax, mild tenderness, non-specific tenderness, but there was a superficial surgical site infection in the laparotomy site. The subdiaphragmatic drain getting like 350 to 450 cc bile daily. We suspected that and anticipated this in the second operation that this drain will get bile. Chest examination, there's a decreased air entry in the right side with no added sounds. We did a chest X-ray. The chest X-ray was there is a pleural effusion in the right side of the chest. These are the lab results. White blood cells is 22 K, mainly granulocyte. His liver function test and kidney function, other tests were normal, chemistry panel, but he has a leukocytosis with hectic fever. Chest X-ray, right pleural effusion. We did a fluorescentesis and examination, microscopic examination of the fluid, transudative fluid. So we inserted a chest tube just for symptomatic relief because he has a dyspnea and tachypnea at the time of examination. After 3 days, the patient still has fever. So after 10 days from the index surgery, he still has a hectic fever with tachycardia. Examination of the abdomen still has a tenderness, non-specific tenderness with mild distension. The wound, the surgical site infection getting to start to get a burst abdomen, the bowel is exposed. The subdiaphragmatic drain at the site of the liver injury is still the same amount with no decrease. So we resuscitate the patient and arrange for urgent re-exploration.
Khalid, why you didn't get a CT scan for this patient with this fever? Did you thought about getting CT scan?
Actually, we did a CT scan for the chest. We were not concerned about the abdomen because we have 3 drains and all of the bile, the amount of the bile is getting out. We did also ultrasound scan of the abdomen. The ultrasound scan has no free fluid in the abdomen. So we were like a little bit assured about the abdomen.
And then what kind of antibiotic this patient is on and what kind of antibiotics available? Do you guys have antibiotics available?
Actually, we have a shortage of certain antibiotics. I'm not aware of them, but all of the time we have to contact the pharmacy here at the hospital to discuss about the alternative we have. But most of our patients with abdominal surgery, we use dual antibiotic using 3rd generation cephalosporin, ceftriaxone, and metronidazole.
Okay.
But I think these are available, but if we have a resistant microorganism, we don't have enough meronym or tazobactam or these broad-spectrum antibiotics.
Okay.
So We decided to do exploration for the patient because the burst abdomen. At the time we do the laparotomy for the third time, the abdomen, the periton was very clean. There is no free fluid in the abdomen, no pus, no biogenic membranes. It was very clean bowel. We still have the bile leaking from the dome of the liver, but after adhesolysis of the a little amount of adhesion. So we did adhesolysis and mobilization to check for the site of primary repair and hepatic flexure. We discovered there is erythroperitoneal abscess, amount of 35 cc thick pus at the site of the posterior aspect of the hepatic flexure. So we evacuated the pus, and actually at that time, the right or the hepatic flexure was friable, thick, edematous. So we decided to do a right hemicolectomy.
So Khalid, just go back. You know, the first case you had bleeding from the liver, things were just not clear enough. So you did the quickly primary repair. It was through and through colon
Yes.
injury, right?
Yes, through and through, small laceration, like less than 1 centimeter from the anterior aspect, and also the same on the posterior aspect. Total just the primary repair of the injury.
Simon, any comment about this through and through hepatic flexure injury? Would you agree on just repair it primarily, or being in that area, you would be concerned about primary repair?
Obviously the teaching is that if it's less than 50% injury, then primary repair is an option. In my practice, this is shrapnel, right, and not a gunshot. But thinking about, in my practice, I see plenty of gunshot wounds. Very rarely ever see shrapnel injuries. But when I see gunshot wounds and there's two of them, and because of the velocity of the bullet, there's surrounding tissue injury, I have a very low threshold to do a resection on a gunshot wound to the colon, because by the time you debride the healthy tissue, and there's two injuries, it's much more likely to be around 50%. And I'm reluctant to leave something that might leak later. So I don't think there's anything wrong with it. I didn't see what you saw, but I would be likely to do a resection when there's two injuries very close to each other in the colon.
Hani, any comment?
Yeah, I would agree. I would do resection rather than primary repair.
Okay, Khalid.
And depending in damage control, I will leave it in discontinuity. I will not anastomose until I take the patient back. But if you don't have ICU facility like some hospitals in Gaza, then I would anastomose, resection and anastomosis.
Khalid, did you check your repair in your second surgery and you were happy about it, or you just kind of maybe slipped under the hectic situation of bile leak?
Actually, the bile leak were contained in the
Did you check your repair in the second surgery? You went for a second surgery. Did you look at the colon repair and you were happy about it, or you
To be
didn't?
honest, we did a formal exploration of the small bowel and the large bowel. It was very clean. There is no signs of leakage at that time.
Okay.
And we did mobilization also of the colon. So there was no signs of inflammatory process at all at the site of the anastomosis or at the site of the repair.
And if I may, I think, the reason that this repair broke down may have less to do with the repair than the associated injuries. For example, if we have an injury of the colon and the pancreas, I basically don't do an anastomosis without diverting, because if you get a pancreas leak, and it's a little bit similar with the bile, the detergent on the outside, a little bit of blood, you get an infection, then all that is eating away at your repair. And whereas if you had just the repair by itself, it may have healed fine. But in that milieu of infection and the bile, which is like a detergent, and if there's any pancreatic leak, the proteinases, it just has a really hard time healing. And that's why. Sorry. The only other thing I would think about is in the return to the operating room, going back to that second case, obviously sometimes the liver is going to leak. You leave bile, you leave drains, and the liver can regenerate and can heal, and the bile leak will stop. But if there's a really badly injured segment, considering a formal resection or otherwise, controlling that injury in such a way. And I would have the luxury of calling my hepatobiliary surgeon in with me and saying, how can we leave a clean surface to minimize the amount of bile leak and give them the best chance of healing? So that's something that with the resources I have, the way I would have approached that return to the operating room in the second case.
I would agree with you about the other co-injuries that participated in this league, and also something you guys don't understand that the severe malnourishment this patient has. If you look at his hemoglobin is 8, 10 days after the surgery, and I can tell you if we look at his muscles, he had have significant muscle wastings, and his ability to heal. I've worked on these patients. We really had problems. So this is a failure of healing. His abdomen had burst. His primary colonic repair that was straightforward, simple at burst. His bile leak is not healing, so I believe this might have some sort of nutritional deficiencies that they don't have the luxury even to diagnose, like some sort of mineral trace elements or mineral deficiencies that even they don't have the luxury to diagnose. So I believe this is a failure of healing everywhere in this patient, Khaled, to be honest with you.
Yes, actually, even with the clean surgeries, when we use after surgeries, we have a high rate of surgical site infection. It's not regarding the sterility in the operation theater. We have a good staff and sterilization, and we have a disposable gowns for surgeries. But actually, as you mentioned, the malnourished, we will decide the post-operative nutritional plan for the patient. We are hesitant to choose which food they are able to take because they are not available in the market to specify we need a soft diet or we need a regular diet. We don't have enough food, or we are not knowing that the patient is able to get these food from the market.
Okay, Khaled, do you want to tell us what happened next?
Going next in the surgery, there was no free fluid collection. I said this. So we decided to do a right hemicolectomy. You might disagree to do the end-to-end anastomosis. At that time, the patient has no peritonitis. The periton were completely normal. We saw that the abscess is only contained in the retroperitoneal area. The periton is completely protected from the infection. And we saw the patient hemodynamically stable. So we were hesitant to do end ileostomy or double barrel, or doing an anastomosis with a loop ileostomy, protective loop ileostomy. So finally, we decided to do end-to-end anastomosis ileocolect because we don't have staplers. We usually, at these cases, do like a Barcelona technique as a rapid technique, side-to-side anastomosis. But we did an end-to-end anastomosis from the ilium to transverse column with temporary closure of the abdomen.
So this is the vac that is for the open abdomen, or something you guys have created?
We have a vac I created. I will send it to you on your WhatsApp. Usually this vac I adapted. It's a vac for the open wounds and the orthopedic. We use a celastic bag, the glycerin 3-liter bag to cover the
So it's not for the open abdomen. I think
Yes,
it's just a regular vac. You have
we just adapted.
customized it.
Yes. So
This is the picture for those who want to see it.
I can share it actually here.
Yeah, you can share if you can share it.
Let me download this first.
But that's fine. But I just show them. It's right there. Can you see it, guys?
Can you see it on the screen?
Right there, yes.
Yes. This is a vac for open wounds, but we put the glycerin, the 3-liter bag, over the bowel to separate the bowel after doing a small incision with a scalpel, 11 scalpel in this bag. After that, we put 2 large abdominal swab over it, and then we put the sponge. We modify it to be at the size of the wound, and then we put the vacuum system.
So, Hani, what do you think about this idea of temporary clothing the abdomen, trying to customize the open wound vac with this, trying to separate the bowel? What do you think?
just before that, I want to add our indication for that, because it's difficult to open to close the abdomen. The bowel were distended, and we when we tried to close it, the peak airway pressure is very high. So we decided to do a temporary closing.
Hani, you want to comment about this way of closing the abdomen?
This vac, is this the one that you used in Nasser Hospital?
Yeah, yeah.
Oh, yeah, I think it's a great idea.
Simon, how innovative is this idea? What do you think?
Yeah,
Sorry,
what we
again?
do,
Oh,
we often will use, in addition to the Abthera, the commercial vac, the Barker vac, which was before, which is similar, which is a plastic bag over the viscera with holes poked in it, an OR towel, an IABAN covering, and then just JP drains or something connected to wall suction. So it's a similar idea that you have the plastic covering, a towel layer, and then you have this vac as the. So I'd be a little bit nervous because I don't like getting too creative, because other people have usually dealt with what I'm dealing with. So I like doing stuff that's been validated. But you guys are in a situation where you have to be creative. So I think looks like a good solution to me.
Okay, Khalid, go ahead.
Actually, sometimes regarding the vac system, we don't have when we don't have this vac or the sponge, we use multiple abdominal towels, and we put two suction drain within these towels after protecting the bowel by a elastic bag like the
Yeah.
glycerine bag. But we, alhamdulillah, we have this sponge vacuum system, so we use that for this abdomen. Okay, I will share my case again.
There was a, if I
So
may.
this is the end of the case. Okay.
No, there
What
was.
do you comment about the anastomosis we did?
Someone put a question in the comment, which I think is a good one, and I had thought to say it and I forgot. Is that with such high volume of bile leak from the liver, what we would usually do is have an endoscopist, or at least consider doing an ERCP and a sphincterotomy to decrease the pressure of the bile in the liver, make the path of least resistance not into the open abdomen, but into the GI tract. That sounds like probably a luxury for you, but someone put it in the comment and it's worth mentioning.
We have access to ERCP and the stenting and sphincterotomy, but actually, because the injury is too much away from the main ducts, we did not thought about. Not thinking about doing the ERCP and
Yeah.
sphincterotomy.
It can just decrease the kind of the pressure in the biliary system, and sometimes make it more likely that the bile goes into the GI tract and not into the wound of the liver. And this is relatively early in the healing process, before they have all these complications. Once you see high output of bile in your drains.
Okay, still have bile leak from this patient? You took him back. His bile is controlled with your drains. You fixed his abdomen. Now this patient should be where's that risk right now?
Now the current situation, today is the second day post-op. He is still in the ICU. I think after this webinar, I will arrange for the operation to the exploration and to have another look on our anastomosis, irrigation, and trying to close the abdomen permanently. But still, actually, a thing to add for his current situation, the lab test for him where all of them are normal except that he has a leukocytosis. Yesterday, the white cell count was 60K, and today it's 40K. We don't know the source of this. I'm suspecting
60?
60,000.
60 or 16?
60.
60 white blood cell count? Wow.
Yes.
Khalid, you asked about the anastomosis, and obviously I wasn't there and things, and this is speculation and not criticism, but I would have a low threshold to divert a patient because we already know he's not healing. And if you can just do an ileostomy, that has its own problems, you can't have high output and problems related to dehydration and kidney injury. But if the anastomosis fails, you're going to have a very difficult situation to manage in the abdomen. And hopefully, if that happens, you'll be able to do an ileostomy. But it only gets harder, right, with the passage of time and the increase of complications and inflammation.
Hani, would you
That
agree about diverting this patient on the second or third operating room?
Yeah, I would definitely divert this patient. Obviously, there is a very, very high risk anastomosis here with everything in hand. So I would definitely divert this patient.
So Khaled, have low threshold. If you have any problems with the way it looks tomorrow, just have low threshold. I know dealing with ileostomy is not
yes.
easy in Gaza. All the ileostomy based bags are not available, to be honest with you, Simon. Patients really suffer to get them available. And then this with the open abdomen, trying to manage a vac with an ileostomy with a bile leak would be disastrous. So I think giving him the benefit of doubt, having him in ICU, I still hoping he would go through it without any leak, but have a low threshold, Khaled.
I will do. Actually, regarding the anastomosis, we have a lot of discussion intraoperatively. Me
Yeah.
and the surgeon, with me, my colleague during the surgery, we have we actually discussed that we want to do a stoma because this is like a third operation. We don't have to risk it, but we have a bad history with our patient with the stoma. As Dr. Osama said, we don't have good stoma care here. Our patient will be sent back to his tent. So still, till now, I have another patient. We did a loop ileostomy, and for the last 1 week, I'm trying to get an stoma appliance for her. I was not able to do that. So because
Because
of that,
again, because the Israeli army is not allowing these things to get in. Just can't
yes,
understand. Ileostomy based bags. There's thousands of trucks having these things ready to go, but again, they don't allow it to go in. Just so Khalid, what kind of options? How if you let's say you go in, things look crystal clean, no problems. What options you have to close the abdomen, knowing that it might be difficult to close? What are your options?
my option at this time is either if it is closing primarily without increasing the pressure, this will be the best, but there's difficulty, risk of the abdominal compartment, so I will do a lateral component separation for him to trying to close it.
So for the question about whether biological mesh available, no, actually they don't have. So what we have used when we were in Gaza is just trying. We were very liberal about doing component separation.
We have a patient with abdominal wall sarcoma. She was diagnosed like 6 months ago. She needed either to be reconstructed with a bilayer mesh or with a biological mesh, but because it was not available, she awaited till last week. Alhamdulillah, we managed to get one biological mesh, which is the only available biological mesh in Gaza till now. So when with Dr. Sarmad, he is a plastic surgeon from UK, he was able to do a reconstruction of the abdominal wall and putting the biological mesh. So the patient awaited 6 months until definitive surgery with abdominal sarcoma increased double or triple the size of its origin.
Very sad, very sad. Thank you. You want to go for the second case, Khalid?
Okay. The second case, this is a 17-year-old female. She came with a mass casualty event, airstrike to her tent and to her neighborhood or the group of tents that she lived in. She lost her mother, her two sisters during this airstrike. And she was the only survivor of her family. On initial examination, there were multiple shrapnel, nearly 3 shrapnels, one in the left infraclavicular area, one in the suprapubic area, and one in the tangential is in her flank. By primary survey, she has a decreased air entry in the left side at the site of entry of the shrapnel, hypoxic. The pulse, she has tachycardia, but normotensive. The abdomen is distended but soft and lax. There is a suprapubic wound, as I mentioned. By ultrasound, there's a mild free fluid collection in the pelvis. There is no by examination also, she lost her sensory and motor nerves in the lower limb. She cannot move her lower limbs. At the emergency department, we did the initial resuscitation of the patient. We inserted a left side chest tube at the site of decreased air entry, and we sent the patient for CT because she was a normotensive. Found CT, there was a left side hemopneumothorax. At the time of the CT, the chest tube yielded more than nearly 700 cc of blood. There was a pneumoperitone surrounding the right colon, mild pelvic collection. Also, there is 3-4 spinal cord injury. The shrapnel entered from the left side infraclavicular area and situated in her right side shoulder. So traversing through the spinal cord at the level of T4. Because of the CT result, we sent her for emergency laboratory.
Go ahead back, Khalid. So, Hani, any comment about this kind of injury? First of all, let's just recap. This patient lost her mother, her sister. She leaves a tent. These airstrikes goes into this heavily populated area with tents. No walls to protect these patients. And you yourself have seen these shrapnels, what they do. What do you think about this injury? As a trauma surgeon, you had been there in Gaza, about, let's say, the outcome of such case in this patient.
Is that question to me, Osama?
Yes, Han, for you, yes. For you.
Sorry, because it was cutting off. These shrapnels are very, very deceiving. Even the things you see on the CT scan, when you open, you find a whole different picture. Definitely, I would expect something major inside the abdomen and the pelvis in this patient.
So, this patient, from just knowing what's happening with all these injuries, she's just a very bad outcome. She's paraplegic. She's, having this spinal cord transverse injury, massive hemothorax, pneumoperitoneum. Simon, what do you think? 17-year-old girl, live in a tent. What do you think?
I don't know. Yeah, it seems like a very challenging place to start, and best case scenario is going to be a huge challenge. And you guys know better than me. I've never been to Gaza.
Yeah. Okay, Khalid, go ahead.
So at this time, we decided to go for emergency laboratory and to watch and see the output of the chest tube to decide intraoperatively if we will go to thoracotomy or not. Because the amount is 700, it's not an indication, and the patient is still normotensive. And during the emergency laboratory, we saw there is a cecal injury, throw injury near the ileocecal valves. So at this time, we did the limited right hemicolectomy with the end-to-end anastomosis with the ileum. Because we don't have staplers, we did it manually, hands-on, end-to-end anastomosis. We have to adapt
I want to ask Simon a question. When was the last time that you did a hands-on anastomosis in the bowel?
It's not totally common, but it's not totally uncommon. If there's not enough space to easily put a stapler in, then we'll do a hand sewn. There are times like a sigmoid volvulus where it's actually easier to do open hand sewn than doing some other. So it's not common, but we still still keep the skill set, and I'll still hand sew the common enterotomy on a stapled anastomosis.
Okay.
So and when I was in training, almost all of the pediatric anastomoses we did were hand sewn to give it the opportunity to expand more. So,
Hani?
Never before I go to Gaza. The only time that I started doing hands-on anastomosis was in Gaza. During my residency, only in pediatric surgery, which was just 2 months rotation when I was a junior resident. So I wasn't even a senior resident in pediatric surgery, I haven't done it. But we've done a lot in Gaza.
Yeah.
A lot, yeah.
Go ahead, Khalid.
So the surgery was straightforward, just limited right hemicolectomy in the ileum and the ascending colon. Postoperatively, the patient was sent to the ICU, actually.
So Khalid, there's a comment from Dr. Matix. He's with us, and thanks, Dr. Matix, for being with us on these webinars. You know, your presence and trying to learn from your wisdom in trauma surgery. He's commenting about this patient is a clearly set up for meningitis, and she should be covered with antibiotics early. Do you think about this, Khalid? Dirty shrapnels going through the abdomen, going through the spinal cord. Did you guys thought about meningitis in this patient?
Actually, no, but the complication that I mentioned at the end of this case explained by like a meningitis or something like that.
Okay, go ahead.
But we also cover our patients postoperatively because this is a bowel surgery. We cover head, prospectrum, double antibiotic. And she's
Ceftriaxone and flagyl, metronidazole.
yes, but she's in the ICU
Yeah.
since the day one after surgery. We cover our patient in the ICU with Murinim and Vanco. It's limited. We don't have a plenty of these antibiotics, but for ICU patients, we can use them.
Okay, great.
So postoperatively, she was doing fine in the first day after surgery, but by examination, she has a decreased air entry on the left side at the side of the chest tube. The chest tube are functioning. There is no bubbling, but the amount of the blood, total amount of over 2 days, 1100 cc blood. So the abdomen relax. The difficulty actually here, because she is paraplegic and she has a level of sensation and motor at T4 at her nipple line, so we cannot assess adequately the abdomen. She does not feeling if she burst flatus or she did a bowel movement or if there is any abdominal pain or distension. We focused. We used like auscultation of the abdomen to hear the bowel sounds. I did digital rectal examination twice to check if there is anything obstructing, because I cannot actually get like a validated thing or a validated examination to check if there is the abdominal problem or not. We did ultrasound twice for her during the last week because she had like a leukocytosis, but otherwise she has a good bowel sound. X-ray of the abdomen, there is no ileus. So we labeled our efforts how to examine the abdomen by these means. Do you have any comments about examining an abdomen in such case?
Simon, paraplegic, T4, motor and sensory loss. How would
You can't trust it. You know, it'll fool you. You're not going to pick up, you know, tenderness, peritonitis, and things from a paraplegic abdominal exam.
I would be liberal doing CT scan, Khalid. I know moving here, it's not something easy, but I would be very liberal doing CT scan for this patient myself.
Actually, hearing a bowel sound and the abdomen, there is no peritonitis. There is no fever. So I was a little bit assured of abdomen because she had developed a new problem. I will discuss later in the next slide. So after 48 hours, she was extubated. The problem here, she developed hypoxia. We used non-breather mask, 15 liter. Despite of that, she's still hypoxic, ranging from 85 to 91. So we did a follow-up X-ray for her. Discovered that the lung, the pneumothorax subsided, and the lung expanded, but it turned into a white lung, a consolidation of the whole left lung. Let me share her X-ray. Okay, there's Sana. So let me share it. You see the X-ray?
Yes.
Okay, this is the X-ray in the first 2 days after surgery. She was improving. She has her SAT was 97 on room air. But after 2 days of surgery, she deteriorated and developed hypoxia and dyspnea. So we did a follow-up X-ray. Can you now
Yes.
see the pneumothorax here? It's
Yes.
obvious.
Yes.
Okay.
So this is like a tension pneumo.
It's not a tension pneumo because it's a tilted, not a dead ABL view, a tilted view. So because of that, the mediastinum is a little bit shifted.
Yeah.
Okay.
But the chest tube was functional? Oh.
Functional. This is the second one. The lung expanded, the pneumothorax a little bit subsided, but the lung turned into a white lung.
So what do you think, Simon, happened here?
So one thing that we should ask is, what is the chest tube connected to?
It's connected to underwater seal.
Underwater.
So it's just like in a glass bottle with the
Yes.
tube going underneath. Is
Yes.
there an air leak? Is there an active air leak from the chest tube?
The air leak is on and off, not all of the time. There's bubbling in the the first day after surgery. After that, there is a high oscillation actually in the tube, but with no bubbling.
Even from that first X-ray troubles me why we can't re-expand the lung. We would have the luxury of suction, which can help evacuate the pneumothorax and expand the lung a little bit better. I saw that you had done bronchoscopy, which is my other thought. Is there a mucus plug or something that's not allowing that lung to aerate? So you kind of ruled that out. And how long was the lung kind of collapsed
At that time,
before
actually,
Go ahead.
at that time, after 2 days of the surgery, I still saw that in the previous picture, there's a significant amount of pneumothorax. I put it on suction, but after doing that, she deteriorated dramatically to develop hypoxia and shortness of breath. I put it in a low pressure, like 25 millimeter mercury, but she deteriorated dramatically, developed hypoxia, and after that, I did the full-up chest X-ray, and I see this picture with expanded lung, but a white lung. I gave her a suspected pulmonary edema or something like that. I gave her a furosemide.
So it's not a pulmonary edema, it's just unilateral. She's still intubated, Khalid? By this time, she's intubated?
The problem in the following part is I did CT scan for her and consulted a thoracic surgeon. He said there's no surgical indication for her, just it might be like a lung collapse or bronchus obstruction. So we consulted the ENT and they did the bronchoscopy. There was no obstruction in the main bronchus. The strange in this case, in the following 6 days, the patient proved in the morning. She was intubated at that time. She was intubated till the morning. In the morning, they did a trial of extubation. It was doing well, and in a room air, there is no hypoxia. Her SAT was 96, 97. But after 6 to 10 hours of extubation, she deteriorated again to develop hypoxia, and we put her in non-breather mask, not responding well, so intubated again. This happened every 2 days in the last 10 days in the ICU.
Any comment? What's happening with this patient?
Yeah, many things come to mind. One of them is pneumonia, severe pneumonia, because it's unilateral. Re-expansion pulmonary edema on one side can happen as well. Aspiration. So sometimes aspiration doesn't show on the first or second day, but the results of aspiration can show later on with the pneumonitis or pneumonia, actually, like frank pneumonia. Doing the bronchoscopy is a very smart idea, I think, and to make sure that there is no like mucus plug collapsing the lung. But to me, it looks like a pneumonia because it subsided for a little bit and came back worse later on. So it looks like an infection.
How would you explain that every 2 days she get better, she get extubated, and then she would be re-intubated? How would you explain that?
I think it's just premature extubation. We should wait a little bit on her because I think because maybe the pressure there on the ICU to extubate the patient. That could have been one reason. The lack of chest physiotherapy because of the limited resources there. That also can contribute to re-intubation post-extubation, even if the patient improves. We've seen that a lot even during COVID. The patient would improve, we extubate them, and then they collapse and get re-intubated again because of the pneumonia. That's why I think what's happening with her is pneumonia.
Okay, Khalid, go ahead.
Okay, after doing the bronchoscopy and we ruled out any obstruction or collapse from the bronchus, the patient did the same over the last 10 days. We did the brain CT actually, and it was unremarkable. The thing that when I go back to Dr. Matuk's comment about meningitis, in the last 2 days, the patients develop like a bulbar syndrome, difficulty with swallowing, and a weak cough response, weak cough reflux. And because of that, we did a brain CT, it was unremarkable, and we did the CT chest follow-up for her. I'm showing this is the CT scan today,
Okay.
22nd of December. Still, there's pneumothorax, collapsed lung. 5 days ago, the lung expanded very well, but this is worse, actually, this is worse.
So how come you still have pneumothorax? Almost now 10 days after the surgery or 2 weeks?
Yes.
But this is an entrapped, I believe this is an entrapped lung with an empyema. That's my thinking now. She has an entrapped lung.
After the CT, we did repositioning of the chest tube and started to have a bubbling in from the chest tube. We decided to make a follow-up X-ray.
Yeah.
But I did not have the chance to see the chest X-ray.
What do you think about trapped lung, Simon, in this case? Maybe it's too early, but maybe it's the case.
How many you did? That's why the failure of the lung to re-expand early really bothered me. If it's my patient, then I can't rest until we figure out how do we re-expand the lung, because right then the complication is it'll never re-expand, and becomes a trapped lung, which is a much more difficult problem. I'm also wondering if there's some injury that will keep the diaphragm from working. I don't know, kind of phrenic nerve injury or something, where is that diaphragm? I guess there was no elevated diaphragm, but why when you switch from positive to negative pressure, off the vent, that she can't keep up? So yeah, I definitely that bothers me that lung won't expand from the beginning. I just got to get that lung to re-expand and figure out. Otherwise, it's going to get trapped. And
Annie, would you think this is an indication for VATS, Annie?
Yes, VATS is a very good option in this case. Why the lung is expanding, and probably one thing I would think of is a bronchopleural fistula.
Yeah.
Or like major airway.
I thought about.
This is why I asked about the air leak.
I thought about the bronchopleural fistula on the first day, but the bubbling were improving. The expansion was good at that time, and the bubbling decreased. I saw like a high oscillation in the chest tube without bubbling, and the chest, actually the lung expanded in the second day after surgery.
Well, I've had a tough case, but I would consider, having thoracic surgery if available to have a look at her and consider maybe that. Basically, the abdomen is fine now. We're not concerned about her abdomen, is that right?
Yes, actually, the examination of the intensivist at the ICU, they saw like there is no movement of the uvula, the patient has difficulty with swallowing, and also a weak cough reflex. They are thinking about a bulbar syndrome, maybe complicated as an ascending hematoma from the T4 or ascending infection from the T4. They are thinking about inserting a tracheostomy for the patient for easier washing and irrigation and suctioning of the trachea.
I would consider that you doing video-assisted thoracoscopy on this patient before tracheostomy, at least at this time. That's me, this lung has to expand and you have to realize what's causing the lung to be trapped. I think that I would consider thoracic surgery to have a look at her and then maybe cover her with proper antibiotics regarding this possible meningitis.
Actually, I sent this CT image for him. I'm awaiting his result or his decision about the case.
Well, Khalid, thank you very much. Any comment, Hani and Simon, on this case before we finish?
Simon?
No, I maybe I'm missing something, but I wonder if the kind of airway and swallowing issues is just the result of just intubation, extubation, intubation, extubation, in addition to all of the weakness and malnutrition and other things that we talked about.
Yeah.
One thing that I want to maybe consider when we operated on her abdomen, we know that she's paraplegic and probably she wouldn't have sphincter control. Maybe giving her a stoma is a good idea in this case. It's better managed than diapers because they don't even have diapers there. They can manage a stoma better. What do you think, Dr. Khalid?
Yeah, I thought about this. The thing that worried me the most from the beginning is if the patient is able to pass stool or not, because there will be a permanent stoma for her. Every day I checked her 3 times at least to see if she is able to sense or to pass. She has a good tone. By just a rectal examination, she had a good tone, but ultimately I think she will need an end colostomy later on after she become improved from the hair chest problem.
Yeah. And I agree with Osama with VATS for this patient. Probably, good washout of the chest cavity and testing for major leak, and stapling this off or resecting that part that is leaking. I think that will give her a good opportunity for lung expansion.
Well, Khalid, I would like. Go ahead, Hani.
I would like to,
the case.
Yeah.
Can I say this case? I will go directly to the point of this case.
Go ahead.
In this case, 17-year-old female brought to the AED. She was transferred from the hospital field away from Nasser Hospital, like 10 kilometers away. She brought here 2 hours after the initial injury. The patient has a small wound at the right side of her neck. There are multiple shrapnels. A shrapnel in the neck, a shrapnel in the abdomen. In the right side of the abdomen, tangential shrapnel inlet and exit. The inlet from the right side of the flank and the exit from the middle of the back. In the initial primary survey, the EFAST, there was no free fluid in the abdomen. Initially, she was tachycardic, normotensive. So we sent her, she Glasgow coma 7/15. We intubated her immediately at the emergency department, and we sent her for pan-CT. I will focus on the abdominal results. There was a right-sided surgical emphysema, retroperitoneal, retroperitoneal. There is a small air dot through the tract, following the tract of the trajectory of the shrapnel, extravasation of the contrast at the right colon, no organ injury, no pneumobariton. There is no free fluid collection in the abdomen. So the neck, there is a small hematoma, is not significant. The brain, there is a significant injury with parietal bone fracture in both sides, pneumocephalus, intraparenchymal hemorrhage with subarachnoid hemorrhage, but there is no midline shift, so there was no clear indication for neurosurgery to intervene. What do you think about, till now, what do you think about the CT result?
Simon, what do you think about this?
Like this? She's normotensive from the start.
Pneumoretroperitoneum with exacerbation of contrast. This is a IV contrast, arterial contrast. Is that right, Khalid?
Yes, arterial contrast. We suspect that the pneumoretroperitoneal might be like a surgical emphysema through the tract. I will leave Simon to comment. I will try to show the CT in the meanwhile.
Yeah, I'd be very interested to see it. I mean, I'm guessing you guys don't have interventional radiology options for angioembolization, which might be an option, but not if it's a right colon injury. But if there's retroperitoneal bleed, that might be an option in New York. Um, but if it's an injury related to the colon or the mesentery, it sounds like it'll require exploration.
I would, again, being in Gaza, I would have a very low threshold of exploring this patient, looking at the posterior aspect of the right colon, the retroperitoneal aspect of the right colon, and take care of it. If I have the luxury of laparoscopy, I will do it laparoscopic. But I've seen missed injury in the right colon with this kind of CT findings. I would have, at least you have to mobilize the colon and look at the posterior surface of the colon there. Make sure they don't have a penetrating injury.
I have the same thinking at that time, thinking about a colonic injury or bowel injury. Colonic injury. So the problem here, the patient developed hypotension the time she came back from the CT. Hypotension not corrected by one or two backed RBCs transfusion. So we were looking about another problem that causing the hypotension, not the abdomen. I was suspecting this is a colonic injury. It will not cause a hypotension within 2 hours from the injury. Let me show you the CT scan now. We will discuss because it has a delayed diagnosis. Can you see the CT
Yeah.
clearly?
Yes.
Okay. I'm going to the right side.
Yeah.
These white dots like an extravasation in the retroperitoneal area.
I see.
Okay.
Yep.
And this is the main trauma here.
Wow. So this is a lot of contrast into the colon.
Yes. Ultimately, it needed a laparotomy.
Okay.
But I'm looking for the source of hypotension. I
Intraluminal.
shifted my mind to because she has a multiple trauma in the brain, and she also has a lower limb trauma with active bleeding. She controlled initially by bandages, but as I said before, we have a delay of transporting patient from the time the field or from the place of injury to the hospital. It takes like 1 to 2 hours, and even if it's an extremity injury, it needs a replacement with a blood component because the patient will lose a lot of blood during this time.
So what did you do? Did you open the colon? Was there blood inside the colon?
Let me go back to the case. Actually, the patient, I was hesitant to do urgent or emergent laparotomy before checking if there is another site of it bleeding. 30 minutes after the presentation, she developed hypertension. We started blood transfusion, but 60 minutes of a presentation, still hypertension. So I decided to take her to the operation theater because I did not find any other source of bleeding. At time of operation theater, the patient passed a gush of blood through her rectum. And discovered it was too late for me because the injury in the right colon. Now it's gushing blood from the rectum. The whole colon has been flooded with the blood. Despite she took like 3 packed RBCs till this moment. During the laparotomy, there was like 1.5 cm laceration in the colon from the posterior aspect. I did a damage control surgery because the patient is severely hypotensive, discontinuity, closure of the abdomen temporarily with a nylon continuous, and send the patient to the ICU.
Well, tough case, Khaled. Simon, have you seen such thing before?
So
bleeding into the colon?
Yeah, bleeding into the lumen from shrapnels.
I don't deal with
is
shrapnel
bleeding.
injuries.
Okay.
But I would say I just early on I would just sometimes the operating room is the safest place to be, and you can work on more than one thing at the same time. You open them up, probably have to resect the colon injury. You can get surgical hemostasis of the extremity, and then get a chest X-ray on the table. Make sure that I mean, this is, I guess, me, but make sure that the chest and the airway issues are under control. And then you can think about doing something else. But waiting on a bleed, especially if I didn't realize you have good IV contrast that demonstrates, the mesentery, especially, the colon can bleed a lot. The mesentery, you can definitely exsanguinate from that. So I think expeditious hemostasis has got to be the rule.
Annie?
Yeah, I've never seen like a case of bleeding into the colon. Initially, I thought with the pneumoretroperitoneum, this most likely could be like a perforation plus bleed from the mesentery. But yeah, the best treatment in this case is what has been done, which is resection and temporary closure because of the hemodynamic status of the patient.
There's a question from Osaid asking both this patient and the one before might need decompression craniotomy. Were there neurosurgeons available for such services? Did they
Yes,
assist?
yes. The neurosurgeon checked her twice, and the brain CT, there was no midline shift. She developed anesocoria from the start, so they started to give her imanotine, I think, but the mannitol is contraindicated in cases with hypotension and hemodynamic instability. The problem here, I thought the same as all of you, that is a colonic injury. I was surprised that a small shrapnel causing this amount of bleeding inside the colon. The periton were clean, totally clean. There is no collection inside the abdomen. After mobilization of the colon, as covered, there's a small hole in the back of the colon and the blood leaking from the mesentery inside it. Unfortunately, this case ended sadly because it was too late to diagnose her and to take her to the operation theater. You see, 1 hour inside our hospital and 2 hours during the way to the hospital. I sent her to the ICU. She was in a bad situation. She developed fixed dilated pupils with refractory hypotension. After 4 hours of surgery, she died and passed away. And the thing I shared this story with you because when we do fast and ultrasound, we did not discover it. When we do the CT scan, we suspected an injury, but we did not discover this is a cause of hypotension or there's a leaking of blood inside the colon.
Khaled, do you want to give us a final comment before we finish?
First of all, I want to thank all of you to join us in these cases. It's very helpful to us for every doctor. Many of my colleagues, I saw them in the participants will benefit from your comments. We usually want to hear from your perspective. We are here on the field. We work in a busy day with crowded cases, with mass casualty cases, but getting these ideas from your perspective will help us a lot. The challenges here is not only in the technical decisions we take in the operation theater, it's also about using the abdominal towel, the shortage of the abdominal towels, the broken electrocautery machines, and the difficulty in choosing in the mass casualty events, choosing the prioritization of cases. Last time I have a mass casualty event, the first thing I do, I stay at the emergency department, send my doctors to the operation room, prioritizing the cases, which is difficult. All of our cases is bleeding, hypotensive. So I have to choose which doing first. And sometimes we have to send cases to other hospitals. We have a field Jordanian hospital and European Gaza hospital. We send stable cases to them just to decrease the load on our staff.
Khaled, there's a comment from Dr. Mattox, Kenneth Mattox. He says, wounds from war. All cases presented today were not soldiers, but young people. So sad. Can you comment about, have you ever seen any injured military personnel that you took care of? Me, I've never. I've took care of almost 150 cases in Gaza. all what I've taken care is females and children's. Have you taken care of any compact military personnel? Or I'm understanding they don't show up to hospitals.
Yes. As I mentioned earlier in the beginning of this webinar, I said that the bombing now, the quality of cases changed because they're bombing tents filled with families, children, women. The majority of these cases will be killed immediately at the scene, and if they are not killed by the bombing, they will be killed because there is a delay in the transportation due to the infrastructure destruction by the Israeli army and tanks. And most of the cases we receive are either children, women, or old men. And this is the case we used. Most of them are guaranteed to be civilians because old age men or women or children living in a tent inside Al Mawasi, which is a highly dense area, they are not in combat, of course.
Any final comment?
Yes, I agree with Dr. Matex. It is very, very sad. The time I spent with you, Osama, there, we've seen more than 1,000 consultation, and we operated in more than 150 case. None of them were soldiers. They were all like women, children, young kids, teenagers, and elderly people. It is very sad, and the thing that's more sad is the silence about it worldwide. Thank you.
Thanks. Simon, final comment?
Yeah, if I may, first of all, I wanted to say that for all the bad news in the world, I'm very, I guess, happy to see Khalid and to be able to lend support. And also, I'm impressed with the state of the conditions, even with all the limitations at Nasser Hospital, considering our communication in February and March and the conditions of the hospital when it was invaded. So I'm grateful and impressed and in awe in some ways of the work that Khalid and your colleagues have done to reinstate trauma care at Nasser Hospital, which, considering the destruction of Shifa, is probably the most important hospital in Gaza right now. And I think in some of the private communications that Serena had shared with me, Khalid once said that it was so important for him to be working at Nasser because where there is healthcare, there is life. And in the consideration of, what more and more people in a position of knowledge and authority are recognizing as genocide, that is so important. So I wanted to recognize that, and that's the reason why I'm very happy and grateful to be participating. And the one other thing that I wanted to say, Osama, you had said earlier that we don't know why the Israeli military is not allowing in certain things, and what I think that we should be clear in saying, and maybe it's easiest for me. I come from a Jewish family. My mother spent time at a kibbutz and growing up, and is still very active in the synagogue. And people will say mean things about us for speaking the truth about what's going on in Gaza. But I think it's very important, and I'm grateful for people like Dr. Maddox, whose voice and experience carry weight in our trauma community, who don't have personal connections in Gaza or are willing to recognize and speak the truth when they see it. But there's obviously an Israeli and, by extension, an American policy to increase civilian trauma, morbidity, and mortality in Gaza. And I think this is where, our, surgical organizations and leadership should be able to recognize the truth. And as people who work to decrease trauma, morbidity, and mortality, there's no way to do it without stopping the violence. And I think recognizing it, speaking about it, speaking about what's going on in Kamal Adwan Hospital, where there are attacks directly on the hospital, is really incumbent on surgical leadership, medical leadership, organizations, institutions, and people like Dr. Maddox. So this is our challenge. I think we can help Dr. Assur with difficult cases, but we got to stop the tsunami of mass casualty events. Otherwise, there's just no way to improve conditions.
Well, thank you, Simon, for being a great supporter for this just cause of Palestinians and trying to stop this ongoing genocides. People like you have a great impact, and you from ourselves due a lot of respect for everyone who speaks out, regardless of his background, regardless of because this is a failure of humanity in common. We all humans, we all care about each other, but seeing these children and young adults just being killed by this cold blood, and they don't even have the hospitals and the physicians to take care of them. That is really so sad. Again, I would like to thank you all. I've been doing this webinar since January, and I'm planning to continue doing these webinars, trying to raise awareness, trying to discuss difficult cases. There's a comment by Dr. Tariq wants to discuss duodenal injuries. Hopefully, I have maybe 5 or 6 cases of duodenal injuries. I can discuss it with you guys. Khaled, if you have some, we're happy to discuss. But again, we know we're going into two days of 2 weeks of holidays, and I know, guys, you, Khaled, are going to continue to suffer, and everyone else will be in holidays. But you have to remember that we, as humans, keep thinking about you, praying for you, praying for all the people of Gaza to save them, and hopefully this nightmare will end up soon. And hopefully we all, as a human, will learn for the future that we have to protect healthcare, protect hospitals, and what happened in Gaza should never happen again. Thank you very much, everyone, and thanks, Simon, Hani, Khalid, Usaid, Dr. Matrix, and I'll see you in 2 to 3 weeks. Thank you, guys. Bye.
Thank you.